Did that fatigue you at all? Did you feel tired at all? Your hand cramp or anything?
Not so much. A little bit.
A little bit of hand
I find
cramp?
myself typing so much these days without actually writing. So this is actually kind of nice.
So if you look at your handwriting here, what we're looking for is if your handwriting font size changes.
Mm-hmm.
You have a little bit of a trend for it to get a little bit smaller, right? So if you look at this one is like kind of the anomaly at the very end, but you kind of see it, the T's starting to get smaller. Like today, look at today there, and then today here, right? And if you don't look at the T, it's kind of the same. Your A's get smaller here, and then you kind of get back up to here. So nothing too significant. Perfect. So when you look at the handwriting evaluation, you can see that there's a little bit of a mixed pattern of handwriting getting smaller, maybe like around the 6th sentence, 7th, 8th sentence they get smaller, and then they actually enlarge. So it looks like a micrographia, then macrographia. And when you see that, it's really just a pattern that's not significant. You really have to see a clear handwriting pattern getting smaller and smaller with each sentence to determine that it's micrographia. And you really have to see the handwriting get larger and larger with each sentence to suspect that it's actually macrographia, like things with cerebellar disease. And a lot of times, you can, if you're not really sure, you can look at one word and kind of see what's going on. And here you can definitely see the A's start to get smaller and then start to get large. But this pattern itself has no real clinical significance. The only other key thing that I wanted to ask during the handwriting section was, does he have any fatigue or any tiredness? Because just from the case review, I suspect he's got some type of head injury. And if you look at the brain region localization form, there's an area involving the premotor cortex that's involved. The frontal lobe, that's really the key thing that's involved. And in those areas, they have an impact on handwriting. And when people have injury to the brain and they haven't been able to recover, before you see symptoms, you'll see endurance issues that really show up first. So handwriting is a really good way to check neurological function and integrity of mitochondria and endurance as you have someone repeat it over again. Now, it doesn't have to be handwriting. You could do any kind of physical examination site over and over again to see if those pools of neurons fatigue. So, for example, you can have a person do finger to nose and they're fine, and you repeat it 4 or 5 times and they keep getting worse and worse. Then you know those mitochondria and those pools of neurons are unhealthy. So this is actually what a handwriting test is. It's just a repeated sentence over and over again. So he was able to adapt, and you can see his handwriting getting smaller, and he's able to fix it. And he did notice a little bit of tiredness or some fatigue that he subjectively talked about, but there's nothing that is very clear or significant. The other thing I should point out with handwriting evaluation was I had him do the Archimedes circles, where he's kind of doing that snail-like pattern. And that's there just to identify any type of significant tremor, and those both looked okay. So when we look at Mark's blood pressure readings, we can see that his seating blood pressure is normal. It's 120/6. And his heart rate is 53, and a normal heart rate is usually around 60 to 100 beats per minute. With certain athletes that actually have developed cardiomegaly with really large heart from training really hard all the time, you can see heart rates this low as part as it's normal. But I don't think that's the case with Mark. Looking at his history, he's not doing extreme exercise that would lead to what they call an athlete heart with enlargement of the heart muscles because they're pushing out their cardiac output so much. So this is something to keep an eye on. Then when he stands, his blood pressure is 116/76. So we're looking for any significant drop, kind of like an orthostatic hypotension pattern. He doesn't have that. So a 4-point drop between 120 and 116 is just potentially blood pressure differences from one time to another. It's not significant enough for us to consider that he's got orthostatic hypotension. And his heart rate is back up to 59. So he's in the low 50s with heart rate. We're going to look at his heart rate a little bit deeper as we do the pulse oximeter testing and test the tissue perfusion. But we want to understand what's happening there because his heart rate is an expression of autonomics. Now, on his brain region localization form in this initial case document, you can see he's got a lot of symptoms of increased sympathetic activity and lack of parasympathetic activity. But with patterns of dysautonomia, you can see things fluctuate all over the place. So his heart rate is something to keep an eye on, and even more importantly, as we put him on a pulse oximeter, we want to really look at heart rate variability, if it's spiking all over the place or not. That can be an indication of dysfunction in his autonomic nervous system. Whoa, you're cold and clammy.
Yeah, I do get
Wow.
this. I get this way.
The color, this.
Yeah.
I mean, so this is really warm. This is like a cadaver.
Yeah.
Human
Yeah. I don't know.
cadaver. Human cadaver. Look at that. Look at that flushing.
It like concerns me. I'm like, why am I so cold?
Okay. You're clammy. You're sweaty.
Yeah.
Your palms are always sweating like that?
Yeah, I get a little sweaty.
Okay. So we're just gonna see if we can draw on it
Mm-hmm.
here. Okay. Nice push here. See those spots? And this can go away, or it's always like this?
It goes away. I think if I'm more active and yeah, it's not always like this, but it tends. If I'm like kind of more stationary or sedentary, I think it can be like this.
Okay. So if you move around and start actually like walking around,
Yeah.
it goes away. Okay. So your capillary refill time, very slow. So if you want to catch that. See how long it takes to turn pink again. It's a delayed capillary refill. Yeah. Okay. Your toes, check out your foot. Human cadaver. And then the same thing here. And it's watching like that, okay. Very sweaty.
Sorry.
It's okay. Wow, like you were just like soaking, like you just ran a mile.
Yeah.
Okay. The refill times here. You want to see a cyanosis there, it's blue. Your toenails, did they get blue on you?
Oh.
Have you noticed that before?
Do they get blue?
Do you notice them getting really blue on you before?
I haven't.
Is there slightly blue there?
Oh, wow.
So you can see from visual inspection and palpation of his extremities that he has some really clear autonomic patterns expressing. Now, you can see his vascular changes really clearly just by looking at his hands. You can see that he's got these pale nail beds in the upper extremity and patterns of cyanosis in his lower extremity. He's got those bluish toenails. And just touching him, I can tell you, it was so shockingly different from proximal to distal. Just from his forearm to his hands, or just from his shin to his foot, was drastically different. Now, I've palpated, people that have cold hands and cold feet or poor circulation, but this is one of the most significant changes that I've ever seen. And it wasn't just that it was colder, but he also had damp, sweaty skin. He was like having lack of blood flow and sweating at the same time, and you saw that blanching response. And that blanching response happens when you push pressure to push blood away, and if the sympathetics are firing way too high, you have an autonomic phenomenon, then you basically see it stay white for a while. And there's some things that can cause blanching, but the most common cause is like an autonomic response. So the combination of, abnormal sweating for no reason with a blanching response and significant temperature changes per capillary refill time, these are all expressions of a autonomic type of dysfunction happening in the extremities. Now, one of the key questions that I asked was, is this something you've had your whole life, or is this something that's new? And for some people, they've had, like sweaty palms or sweaty legs their whole life, and they're just wired differently. But when you hear someone say, no, this is not, I haven't had this my whole life, I've only had this the past 5 years, and you look at the mechanism of microglial priming and injury to the brain, and over time, as the condition gets worse, he reports that his injury was 10 years ago, and he's having these symptoms about 5 years ago, and that's just a guess. But it gives you a timeline of it actually developing. So this is definitely starts to show patterns of dysautonomia. And when we see chronic gastrointestinal issues that just don't respond to everything with diet, nutrition, lifestyle, and supplementation, and everything, one of the diff dies is something like this, dysautonomia patterns. So this is something I want to keep an eye on, but it's a really great example of seeing these autonomic phenomena in the limbs. Now, also, I would point out, when you see these autonomic phenomena in the limb like this, it's not just the sweating palms or just the cold feet, but a combination of abnormal sweating with blanching responses and the significant temperature changes like that. And they're all kind of adding up together. It's very significant. That is a pattern you're worried about if there's an injury to the limbs for the person to develop complex regional pain syndrome. And remember, with complex regional pain syndrome, the sympathetic system is already being expressed at an exaggerated rate in the limbs, and that exaggerated activity sympathetic response combined with injury that then increases nociception and further sympathetic responses can then cause negative plasticity and wiring of those chronic pain patterns. So his dysautonomia puts him at significant risk right now with expressions he's having in his limbs for injury to his limbs and developing complex regional pain syndrome.
Like I'm not like nervous or anything. I literally just sweat.
Let's check out. Take your shirt off. Look at your skin and try. Okay, let's just poke around here. So you have some of that as well. And have you been having these hand feet since you were a kid, or is this something since the past 10 years, or?
I don't remember it being my whole life. I think it's more recent.
How many years?
Maybe it's hard to tell. I've definitely noticed the past 5 years.
Past 5 years. What I want you to do is, if you can take your glasses off for a second, I just want to have you pull down your inner eyelids so I can take a look. Okay, perfect. Understand? Okay, great. So when you look at the inner eyelid, you're looking for lots of redness, healthy blood flow. And if you see any signs of paleness, then that makes you suspect that there may be some patterns of anemia. Now, his color is really kind of in between. It's not really clear pale, but it's not necessarily a clear red. So we really want to look at the CBC, make sure that's one of the profiles we ordered to make sure he doesn't have any patterns of anemia. If you see patterns of hypoxia and autonomic dysfunction and poor vascular blood flow in combination with anemia, there really is no chance for his brain to recover. So this is something we need to look at, and you'll see that on the laboratory workup that we need to do on Mark, we'll have to have a CBC there. So when you look at the pulse oximeter reading, we're really looking at two things. We're looking at the SpO2. He's at 97%. We're going to check that a little bit longer, but I'd like to see it's at least 98% or higher. And then when you look at his heart rate is 56, normal 60 to 100. So it's just a little bit low, nothing to be worried about. But the most important thing is to look for heart rate variability. So heart rate variability is a pattern of dysautonomia. Now, unfortunately, with dysautonomia, you don't always have expressions in your office. Sometimes when they're in your office, the autonomic system is intact, and then other times, the heart rate's all over the place. So there are times where you may want to have a patient look at their heart rate, or even wear a heart rate monitor, and then throughout the day, and when they start to feel anxiety or start to feel a little bit off, to look at their heart rate. But right now, we don't see any unstable patterns of heart rate, and you should know that these do fluctuate all the time throughout the day. So if you don't see it during your exam finding, it doesn't mean it doesn't exist. Okay, this is just gonna start measuring your perfusion index. Get a better idea what's happening with your circulation. So, pulse rate. So your pulse rate's 57, which is pretty good. Measure your pulse ox is good. Perfusion index. 8.0. Okay. We're going to wait a little bit longer, see if we can get your red blood cell hemoglobin. It just takes a little bit of time.
What are those?
Those are just for the ophthalmoscope. They're just being charged.
Oh, okay. It's like, wow. Maybe I should get those for my house. That's cool.
Hey, so you working now?
No, it's just a vent. So when you look at the measurements of his SpO2, they're running between 97 and 100%, and then his PI on this device is the perfusion index, and that perfusion index is sometimes above 1, sometimes below 1, but it's kind of going all over the place. He has levels that are on the low end or below normal, but his blood pressure seems to be okay. And if you look at his heart rate is 56 and it goes up to 65, and then it kind of stabilizes at 56 to 58. So technically it's still within the normal limits, but really on the borderline. Like, you don't really want to see the heart rate go from 56 to 65 in under a minute just sitting there. Same with the perfusion index. So this really makes me suspect that he has some patterns of irregular autonomic function, and it may be much worse in a different setting. He certainly has autonomic signs of vascular issues and symptoms of it, but it's not something that's screaming that it's totally abnormal. We don't see huge shifts of variability, at least during the exam right now.
Sub-zero.
75. So here you can you see it?
Mm-hmm.
It's starting to get warmer.
That's crazy.
There's like 90.
What did it say?
75.
Oh, wow. Yeah. Yeah, look.
It's like a 15-degree difference.
That's absurd.
So this is important for us, because if your circulation's this bad in your hand and feet,
Yeah, you never know what's going on.
the circulation's this bad in your brain.
That's not good.
And when we have a brain endurance issue like you have,
Mhm.
we have to really figure out how to improve your circulation, because it's going to impact your brain energy levels.
Mhm.
Okay. Yeah, pretty much same thing. Close your eyes. One. So when I look at the surface temperature of his limbs, there's a huge difference between proximal to distal. Even from his elbow to his fingertips, there's a 15-degree Fahrenheit difference. And it's the same thing with his knee down to his toes. So even just mid-limb, you see a huge shift. Now, we know his SpO2 is normal. We know he doesn't have any signs of difficulty with breathing or any issues or symptoms with exertion that you would see with any kind of cardiac problems. Obviously, we're going to listen to his heart and lungs and make sure those are healthy, but for the most part, these are all autonomic. And these are really patterns of sympathetic tone. Now, let me make it really clear. You're not going to give someone like this a GABA product or something to calm down his parasympathetics from a nutraceutical point and have any change on this. It would just be really wasting the patient's time, energy, and money. This is a consequence of brain injury. And until his brain heals, you're not going to really see these autonomic patterns change. So throughout the exam, we're really focused on where is the brain injury, What kind of clinical findings are we seeing? Do we even see signs of brain injury? Is our diagnosis correct? But right now, there's just a red flag for dysautonomia, and the question is what part of the brain is injured. And remember, general brain injuries impact autonomic centers, so the autonomic centers of the brain all throughout the brain. So injury in any part of the brain can cause different patterns of dysautonomia. We just don't know where it is and what to do about it at this point. Lungs, just breathe normal, and then your heart. Go ahead and bear down like having a bowel movement.
What does that mean?
Like,
Oh.
okay.
Like hold your breath? Kind of
Okay.
thing? Okay.
Okay, now every time I place this on you, take a deep breath in through nose and mouth, and then all the way out. Okay?
Through my nose?
Yeah, go through your nose and mouth. And all the way out.
Okay.
Just keep doing it. Every time you feel it. Come over here.
Yeah, I'm sweating. Sweating it out. It's like a sauna.
It's a little hot in here, but
I tend to sweat when I'm cold, though. It's weird. I don't know why that happens.
deep breath. Looks like you've been running. Mark, does your skin ever feel like it's burning, or do you get any itchiness or anything?
Not so much.
So in this part of the exam, I'm just auscultating his carotid arteries. I auscultate over his thyroid, then listen to his heart and lungs. So I first start with carotid artery auscultation just to see if there's any abnormal sounds, any bruits. Then I have him bear down. Sometimes that can bring out a bruit. And then I listen over directly in front of his neck, right over his thyroid gland. And this is because when you have people that have hyperthyroidism, they will have some autonomic changes and increased sympathetic responses. Thyroid hormones increase metabolic rate, and thyroid hormones also increase sensitivity of epinephrine, norepinephrine receptor sites. So this is when people are hyper, you'll see them really sweating and having some similar autonomic phenomena, but usually they're very nervous and very anxious, and the heart rate is easily over 100. He doesn't have those presentations of hyper, but during auscultation, I still want to listen to it. Now, normally you shouldn't hear anything over that thyroid gland, unless they're hyper, and then you may hear some swishing or some blood flow over it, and his were fine. And then his heart and lung sounds were fine. There's no abnormal heart sounds, no abnormal lung sounds, and there was some significant sweating. And he makes this note that he's having this response where he actually sweats when he's really, really cold. So again, these are patterns you see with dysautonomia, and they're very subtle, but one by one they start to add up. And then if you look at the symptoms in the brain region localization form, where there's symptoms of always having a sympathetic dominant or parasympathetic that fluctuate throughout the day, these are patterns. Now, dysautonomia is really important for us because he has chronic GI issues that he's been troubled with, and these have been taking place for over 10 years. And these autonomic imbalances that put a person into a sympathetic load are going to absolutely shut down parasympathetics, and that may be why there's such significant digestive issue patterns. Keep your head down. I'm gonna just palpate your thyroid. And swallow. So when I palpate his lymph nodes, everything's fine. There's no lymph node enlargements. And then I do a very thorough palpation of his thyroid gland. Now, he's got a big Adam's apple. Don't let that big Adam's apple or that big thyroid cartilage make you think he's got a goiter. He doesn't have a goiter. And when you palpate his thyroid gland, it seems pretty healthy. Now, one of the other things that may cause some of these symptoms besides a hyperthyroid response could be what's called a toxic thyroid nodule. And sometimes the thyroid gland produces a nodule that can release thyroid hormones and really put someone into a hyperactive state. So I did a really, really careful palpation all throughout the different lobes of the thyroid gland and moved his head position around. And I got into lower lobes and palpated and really didn't feel anything at all. So it was a normal thyroid palpation. But one of the other difficulties when you see a lot of sympathetic responses and hyperactivity like this, besides hyperthyroidism associated with like Graves or something, is just a toxic thyroid nodule, and his thyroid palpation was normal. You don't have any activity going on.
Digestive what?
Your intestinal contractions, they're just not there. Very weak.
Yeah, I ate like about an hour and a half before I came here, and I still feel like my whole meal is in my stomach.
Yeah. Yeah. It's a very faint sound, and there's Lots of delays in between each contraction.
Sometimes when I'm falling asleep and I know I get the sense that I'm not digesting, I'll have to get up and take some HCl and enzymes, even without a meal, just so that I'm not like sleeping on a full stomach.
So when I listen to his abdomen, I'm just listening for any abnormal bowel sounds. He doesn't have any abnormal bowel sounds, but what he does have is just really, really faint contractions and lots of time between one contraction and the other. Now, sometimes if someone hasn't eaten for a while, you may hear that, but he reports that he ate about an hour and a half ago. So if he ate about half an hour ago, we should be really hearing those muscle contractions happening, and we should hear some consistent peristalsis activity, but he just doesn't have it. Now, if you're not listening to patients' abdomens, you may not be able to tell, because you're going to have to listen to, 100, 200 abdomens to really start getting a sense of what's normal and what's abnormal. But usually when you're struggling to hear one contraction and then there's a long delay between another one, and then when it does contract, it's really faint, that's what you see when there's lack of gut activity that's taking place. So we're really seeing a pattern of impaired peristalsis. Now, part of the reason could be he's just in a sympathetic overdrive, and if you're in a sympathetic overdrive, you can dampen parasympathetics. But there's other possibilities too. At this point, all we know is that his gut motility is impaired, and he has very weak contractions despite eating recently. Is that painful at all?
No.
Just besides me poking in.
No pain. Well, I will say last night and a few nights ago I had some pretty intense, whether it's ileocecal or whatever, this here is just pulsing and just severe pain.
Do you feel like food gets stuck sometimes? And
Yeah.
your gut's fighting to move it?
Yeah.
That's probably what it was.
Mm-hmm.
So his abdominal palpation and percussion is normal, but he does report his symptom of having food stuck. And it's really common for when people have motility issues to complain right over the ileocecal valve. The ileocecal valve is really the key valve that keeps tone between the small intestine and large intestine. And it's really common with people that have peristalsis issues to have a lot of significant discomfort in that area. So he's showing the classical pattern of impaired gastrointestinal motility. I just want to add, I know there's a lot of people that do visceral manipulation work and even do therapies for ileocecal valve. You have to understand that this is not an ileocecal valve problem. This is a dysautonomia pattern. So, you can do visceral manipulation or different types of therapies to stimulate the ileocecal valve. And those things may have some short-term benefits, because as you induce stretch in those smooth muscles of the gut through different types of pushes and pulls, you do get one afferent vagal input for a little bit of time, which may seem to help the patient, but it's just never going to last, and it's really more of a top-down effect. So I just wanted to add that in, because I know there's a lot of people that would typically ask that question, so I just wanted to address it. So I would only point out that if you do visceral manipulation or things with the ileocecal valve, you would expect to see some short-term benefits from that may last half an hour or an hour in cases like this. But it's going to reoccur because this is a dysautonomia pattern top-down. It's not necessarily something wrong with the valve itself. There's not like a stuck gut or something like that. It's a neurological issue. Put your headpiece back. I want you to know if that makes you dizzy at all. Not really. The other way. Any problems?
Not so much.
So with the Klein's test, you take the patient's neck, you put it into rotation, and you extend their head back. And this is a test for vertebral basilar insufficiency. If really, really extreme cases, I'm not really expecting to see any patterns of vestibular basilar insufficiency. But when people do have head injuries and it does impact their vestibular system or cerebellum, sometimes when you put them into this position, they may notice some anxiety or some changes in their autonomic function. They may have changes in their flushing response, or their eyes may tear, or you may see some type of change like that. He didn't have any of that, so it was just as part of the screen. It just rules out that there may not be any vestibular patterns induced by positioning of the head.
Yeah, it's weird. Like, I don't know if it's subconscious, but I feel as if because my stomach is full, I'm not taking as deep breaths as I could because there's only limited space.
Well, respiration, deep breaths, is also parasympathetic.
Right, yeah, those out breaths. Like,
Yeah.
So I wonder if I'm not breathing in all the way because of like a full stomach or like...
You might, yeah. So the way this test will work is I'm going to block your nostrils. This here, you can adjust it if you want.
Here's your Christmas card.
There you go.
You're going to put this on here. You're going to blow into this tube. You're going to take a deep breath in, push your lips around the tube,
Okay.
and blow in as hard as you can. Okay? Perfect. There we go. Take this off. Okay, yeah, you're good. Everything is great.
That was a normal reading.
Yeah. Now, Mark reports some problems with respiration difficulty, but, when you look at his spirometry measurements, they were all perfect. They were all normal. And his heart sounds are normal, his lung sounds are normal, his SpO2 is normal, so there's really... It's very unlikely that there's any kind of lung pathology or lung disease there, and he has no symptoms associated with those patterns. However, there are autonomic patterns that can cause respiration difficulty. So he feels like there's potential that he has lots of gas in his stomach, and that may be pushing up his diaphragm so he can't take a deep breath in. That's a possibility. But when you look at autonomics of respiration, the way things work is there's an interplay between parasympathetic and sympathetic activity to have normal respiration. So we have, our carotid body receptors that are going to be working with chemoreflexes to measure our CO2 concentration. And when our CO2 concentration impacts these chemoreflexes in our carotid body, that's going to then activate brainstem centers called respiratory pattern generators in the nucleus sultoris that then activates the sympathetic areas of the brainstem, specifically the rostral ventrolateral medulla, known as the RVLM. And then the RVLM will be involved with taking respiration activity in and bronchodilation and sympathetic activity. And then the pace of respiration is going to be generated by pneumotaxic centers at the lower areas of the brainstem that are parasympathetic. So there's interplay between sympathetic and parasympathetic activity. So some of his respiration difficulty may really be from the dysautonomia. It doesn't seem to be from anything happening with the lungs themselves. I'm going to have you smell something. Why don't you tell me what they smell like?
Okay.
Since when you had that issue where you had head injury, you had smelled that, tasted and smelled garlic.
Garlic.
Have you had any issues with taste and smell since?
No, not so much.
Okay. Go ahead and block one nostril and tell me what this is.
Licorice.
Okay, and block the other side and tell me if it smells the same or different.
Same. Oh, it's really it's like an ash, like cigarettes or something.
Okay.
coffee.
Yep. Try the other side again.
It's weird that
You're just used to high quality coffee. We have the cheap stuff here.
I smell it now. Yeah, it sounds like maybe like it's the burntness.
Is it the same from left to right?
More or less, yeah. I smelt it more on the right, the coffee register.
So during the evaluation of smell, we can see that he has a pattern of dysosmia, meaning that he has dysfunction on recognizing scent. And with his left nostril, he really describes smelling coffee as burning or dirty cigarette smoke. You can even see his facial expressions of disgust when he smells it with his left nostril. And the same exact scent on the right nostril doesn't seem to bother him. You don't see those facial expressions of disgust, and he then actually recognizes that it's coffee. So this is a concern for us because if you remember from his history, when he had his traumatic brain injury, that he fell in the back of his head skateboarding, and it's possibly he had a counter-coup injury in which the back of his head pushed his brain forward, but there's also the possibility he may have directly injured his frontal lobe. It's not really clear from his history what part of his head was hurt and where. It was so many years ago. But sometimes with injuries to the frontal lobe, those olfactory nerves pass through the cribriform plate and they can get injured. So he reported smelling garlic for many, many months after that initial head injury, which is really epileptiform activity or spontaneous seizure-like activity. Now, it's very unlikely he damaged the area of the brain that sense smell because he doesn't have any other symptoms of that after the injury. And the areas of olfaction are in the inferior deep temporal lobe, which is pretty hard to injure from impact. However, it's really easy to shear those olfactory nerves as they pass through the cribriform plate of the skull. And it seems like he has some injury to those nerves, and that's why he has some dysosmia. It just lets you know how significant that initial injury to his brain may have been to cause some shearing injury to those olfactory pathways. And these are ipsilateral, the injuries on the same side of the injury. Okay, I'm going to give you a napkin. You're going to wipe your tongue with it. I'm going to put some different solutions that have different flavors on your tongue. You can tell me if it's sweet, salty, or bitter.
Okay.
You're going to stick your head back and stick your tongue out. And put a drop on your tongue. Okay, tell me if this is sweet, salty, or bitter.
Salty.
Okay, wipe your tongue. Stick your tongue out.
Sweet.
Okay, great. Wipe your tongue. So when we check his sense of taste, we're really evaluating his gustatory pathways. And he can perceive salt and he can perceive sugar, so those are all good signs. Now, if you look at the neurological pathways for perception of taste, there's really two areas of the brain that are involved. One's the insular lobe, which is really deep in the parietal temporal fissure, which is really hard to injure from traumatic brain injury. But there is also an area in the inferior frontal gyrus that can be involved. And with him, there doesn't seem to be any problems there, which is a good sign. Take a look at these colors. Tell me if, and block one eye, and tell me if they're the same degree of contrast from one eye to the other.
Can you describe that one more time? Just same degree of contrast?
Yeah.
Which
So
one?
this one has, let's say, greens and blues in there.
Oh.
Obviously, you can see the number, right?
So I'm comparing left to right?
No, just look at this one.
Oh, just, okay. Yeah.
Okay. So you can see me here using the Ishihara test, which is normally used to look at color blindness or color deficiencies, but I'm not using it for that in this purpose. I'm having him look at one of the images and to see if there's any differences in color contrast between one side or the other. And the reason I'm doing this is because I know he had a potential injury to the back of his head when he fell skateboarding, and if the occipital lobe is injured, you sometimes see drastic differences in color perception from one side to the other, and his seemed intact. He also didn't have any significant symptoms of occipital lobe dysfunction or injury in the brain region localization form, but it was just part of the evaluation of his brain. Look over here. look over here. So you can see the coronal reflex is intact. If you remember, the coronal reflex has a sensory portion of the trigeminal nerve over the V1 distribution that then causes a reflex with quite nerve 7 to cause the blinking response. So it's really looking at the integrity of the lower middle parts of the brainstem, and his intact. It's just part of a normal cranial nerve exam. I'm going to touch your limbs with this tissue mark, okay. And I want you to tell me where it is or point to where it is.
Okay.
You can tell me.
Same.
So here we are testing light touch throughout different regions of his face and limbs, and these are just basically evaluating either sensory nerves, or they're evaluating the integrity of the parietal lobe on the opposite side, and he's intact. You're going to close your eyes. As soon as you feel this on your feet, you're going to say, now, okay?
Now. 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 No. 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 No.
Okay, so here we do a monofilament test. And the monofilament test really looks at large 1/8 afferent pathways from the sensory proprioceptors of the limbs up to the brain. Now, he has somewhat of a glove and stocking pattern of sensory loss, and that happens with poor circulation in the hands. It also happens with diabetes and different types of neuropathies that injure the distal nerves that carry blood flow to the limbs. So there's actually injury to the nerves that supply the blood vessels, and you get all types of vascular dysfunctions. And he's got some of the vascular phenomena of that, but usually like with patterns of diabetes or other types of neuropathies that are involved in the classic glove and stocking pattern, you usually lose 1/8 afferent large diameter fibers first, and that'll show up with a monofilament test. So his is intact, which really goes back to this is not really a neuropathy. This is really just dysautonomia and circulation and blood flow issues that we're seeing with this exam. This is a pinwheel, okay? It's clean, no one's used it. I'm going to open it, and I'm going to have you feel it with your fingertips so you know what it feels like.
Okay.
Yeah.
Okay.
And I'm going to stroke left and right parts of your face and arms and have you compare left to right. Tell me if it feels the same.
Yeah. Yeah. Mm-hmm. Same. 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 Same.
So here we evaluate pinprick sensation, and we're evaluating pinprick sensation for a few things. First of all, we're just checking small C fiber neuropathy activity, and they seem to be okay. And then also remember, anytime you test perception of temperature, light touch, vibration sense, you're also evaluating different cells in the contralateral parietal lobe. Now, my major concern with doing the pinprick evaluation is, does he have any patterns of hyperalgesia? So that would be a strong concern for him to potentially develop complex regional pain syndrome. So I'm running through the pinwheel, and I just want to see if he feels like the pinwheel feels like a knife, where you have this abnormal nociceptive activity from the sympathetic tone. And the good news is that he doesn't have that. Now, if he did have that, we're just stroking the pinwheel across his skin, makes him jump like a hyperalgesia pattern, then you know that the sympathetic drive that's happening is really sensitizing those C fibers really, really aggressively, and he's really has susceptibility to developing a complex regional pain syndrome. And at this point, we know that he doesn't, so that's really good news. I'm gonna have you close your eyes. I want you to tell me which one is cold, okay?
Okay.
This is number 1, and that's number 2.
Okay.
Which one's cold?
2.
This is number 1, and this is number 2.
1.
1 was colder?
Yeah.
You sure? Can you tell? Let's try again. Here's 1. Here's 2. Which one's colder?
2.
Here's 2. Here's 1. Here's 2. Can you tell?
Do it again. 1 was colder.
Okay. Here's 1. Here's 2.
1 cold.
Sure.
Feels like it.
Okay.
Maybe it's the temperature of my hand.
Well, I'm asking if you're sure because you're getting it wrong. And
Yeah,
you have
maybe
no
it's-
time. Keep your eyes open. Now, you're not getting enough blood flow there, so it's probably just circulation. Keep your eyes open. Can you tell the difference?
It's hard. Yeah, it's actually pretty hard to tell.
Much easier up here, right?
Oh yeah, that's weird. It's like
And
stark
easier,
difference.
Easier here.
Yep.
But then when we get down here,
It's
hard.
It's hard to tell.
yeah, that's
Yeah.
related to your circulation. You're losing
Yeah.
some temperature and sensation there. So when I test cold perception, you can look at this instrument, and then the plastic side is warmer than the metal side, which is cold. He really has a difficult time distinguishing cold sensation versus hot sensation, and it's pretty clear that the more distal I go, the harder time he has with it. It's much easier when I go proximal. So this is what you see with people that have really bad circulation. I mean, really bad circulation to the point where their sensory fibers are a problem. Now, if you remember, he had a 15-degree difference in temperature because of his pattern. So it's not uncommon to see this type of response. It doesn't have any signs of neuropathy or any kind of skin changes or any kind of large 1/8 afferent loss you see with monofilament test. We're going to have to check his vibrations, as I'm sure that's going to be intact. But the most common thing that you'll see with people that have really, really bad circulation in their hands and feet is they just have a really hard time distinguishing temperature perception. And the best way to tell if that's happening is to then go more proximal, and you'll see that it's better more proximal. And then the other types of sensory testing are typically recognizable. Go ahead. Do you feel that vibrate? Close your eyes.
Mm-hmm.
Yeah? Tell me when it stops.
Stop.
Feel it vibrate?
Yeah.
Tell me when it stops.
Stop.
Feel that vibrate?
Mm-hmm.
Tell me when it stops.
Stop.
And vibrate. Tell me when it stops.
Stop.
So you can see with vibration perception testing, he's intact, that he can tell when the vibration stops in his distal tissues. And you can also notice that severe blanching that happens with his skin because of his inability to shunt blood back into his limbs once there's pressure applied to them. But this just lets us know that those large 1A afferent fibers are intact, that even though he's having some of these difficulties perceiving temperature and some of these changes in his vascular function, he doesn't have a large fiber neuropathy. When I put something in your hand, I want you to tell me what it is.
Rubber band?
Okay, tell me what this is.
Paperclip.
Perfect. And when you draw in your hand, tell me what letter you're reading.
O. T.
Okay.
Or X.
Okay, open your eyes. So this is going to be number 1. Okay, you
Okay.
touch this, that's number 1. That's going to be number 2. This is going to be number 3. This is going to be number 4.
Okay.
Close your eyes. Which one am I touching?
2.
Which one am I touching?
3.
Okay. And which am I touching
On the left?
On the left, 3.
On the
On the right is 1.
So you can see testing for stereognosis, graphesthesia, and extinction are all intact. This just lets us know his parietal lobe is nice and healthy, and we're not really worried about any injury to that region of his brain, and he doesn't have any patterns of peripheral sensory dysfunction. Tell me if you feel 1 or 2 metal prongs on your fingertips, okay? Eyes closed. 1 or 2.
2. 2. 2. 2. 1.
And here.
2. 2. 2. 1.
Here you can see we're doing 2-point discrimination testing, and it's intact. Now, you have to remember something really important about the parietal lobe and parietal lobe injury. Within the parietal lobe, there are specific cells that just perceive temperature. There are specific cells that are involved with perception of vibration. There's specific cells that are involved with pinprick, and there's also specific cells that are involved with proprioceptive discrimination, like 2-point. So all of those are intact. We always want to check all those when there is any kind of history of brain injury. And you can see with that instrument, it's really easy to go through and check 2-point versus 1-point as you change that octagon shape. There's different distances between those little prongs that he perceives. It's a great tool. If you don't have one in your office, you should definitely get a 2-point discrimination tool like that. Can you visualize your left ankle? Like feel where it is in space?
Mm-hmm.
Can you visualize your right ankle?
Mm-hmm.
Do they feel the same or different? Is it easy for you to distinguish where the left and right are?
Yeah.
Okay.
They're the same.
Do the same thing with your left and right wrist.
Okay. Yeah. Same.
This is just another test to evaluate parietal lobe function. Remember, the parietal lobe is getting somatosensory information from muscles, joints, and ligaments, and then going up the brain, and then synapsing into the parietal cortex that has a somatotopic map of different parts of the body. And again, everything is intact. Now, sometimes when people have parietal lobe injuries that cause dysautonomia, you'll see when they start to perceive different limbs, they have a hard time doing it. And for some of them, you will absolutely see them go into like a sweating attack, and the heart rate goes up, and they get anxiety. And that's what you might see with someone who's got a parietal lobe injury leading to dysautonomia. Now, he doesn't have any of that, but I just wanted you to know why I was doing the test, and just, again, confirming that there's no injury to that region of the brain. That's the main point of that evaluation. Okay. Then your corneas look aligned, light reflex. Great. So here I'm looking at the pupil light responses. I initially just align the pen light so I can hit both pupils nasally just to look at the symmetry of the pupil responses. They were intact. And then I went and tested direct and indirect light responses. Those were intact. And then I did the pupil light reflex or corneal light reflex, where you just shine the light straight ahead, and you see if the pin light is hitting the eyes exactly in the same regions, and all of those were intact. So this is just looking at the integrity of those visual pathways and the autonomic responses that take place with the endoretinal nucleus, and to make sure that he doesn't have any patterns of strabismus or eye muscle weakness involving cranial nerves 3, 4, and 6. So basically his upper brainstem regions are all intact. Okay, we're going to look inside your mouth here. Now, let me ask you a question. Do you have a problem swallowing?
Not so much.
Oh, I thought you said you had some problems swallowing.
Did I?
Yeah, on the forms.
Sometimes when I have to, when it's like a lot of pills or something, and sometimes when I have to repeatedly swallow, then it becomes an issue.
So it's not the first swallow, it's the...
Yeah, it's usually not the first one.
Okay.
So maybe that.
Yeah, that helps us understand. And then do you ever get dry mouth?
Yeah.
Okay. So take a look here. Just looking at your salivary ducts. Looks like you're producing saliva. That's good. Nice and shiny. Nice saliva production there. Okay. Go ahead and stick your tongue out. Say ah.
Ah.
I want you to keep doing that 10 in a row.
Ah. 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 Ah.
There, you're gone. It's hard. It's hard to do.
No, not too much.
Okay. Did you feel it getting weaker each time?
Maybe I wasn't trying as hard. No.
We're gonna have you try it as hard as you can.
Okay, I'm down. I think the dehydration, I just want to note, like, or the salivary from dehydration, like, sometimes I've noticed that.
Okay.
If I'm dehydrated, I'm like already full of food, and then I just don't hydrate, and then I get
You're in trouble.
more dry mouth.
If you have fiber, do you get worse? Do you get like food stuck in your body?
Yeah, yeah. So I'm always like, should I eat more plants or not? Like,
Right. Did you getting the tally? Okay. So you're gonna go. You're gonna do
Okay.
okay.
Oh, like 10?
Yeah.
Ah, 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 ah.
Okay, that's pretty good. Just take away. So your palatine muscles, everything is working, and then it does get a little weaker, but that's still normal there. Okay. Get your gag reflex here. There you go. Great job. This is a really important part of the exam. This is the evaluation of his gag reflex, his palatine muscles, his saliva production, and just a general look into his mouth. So when he opens up his mouth, one of the first things you'll always notice is a person's breath. And if people have significant patterns of fermentation and dysbiosis, you'll see that they have really bad breath, and they may have a coated tongue. But he's pretty healthy there, so there's no issues with that. And then just a quick look at his tongue, it looks healthy, and look at his gums, it looks healthy. And then I go in there and just look at those saliva glands. Now, the salivary production is really important because that's parasympathetic activity. And you have a cranial nerve 7 and cranial nerve 9 nuclei, the superior and inferior salivatory nuclei in the lateral areas of the brainstem that control salivation, but they're parasympathetic. And if they're working, you can actually see little bubbles of saliva by the salivary duct, but more importantly, you just see a shine. Saliva shines when it's throughout the mouth. If you ever see a mouth that just looks dull, it's not shining, then you know they're not producing saliva. So he's able to produce saliva there. And then the next part of the exam is just to look at his gag reflex. Now he reports that when he does repeated swallowing, he seems to have an issue. So I check his palatine muscles and I have him do it over again and repeated palatine muscle contraction. We talk about doing this in the gastrointestinal module. But when you have a person repeat the test, you really challenge those mitochondria and those pathways, and they should be able to do 10 without any problems. And for some people, they'll just fatigue. After a 4 or 5, you'll just see those arches, those palatine muscles not moving when that vagal nuclei is not healthy and not doing its job. Now, in him, it looks like he was having failure at the very end, but when I asked him about that, he's like, oh no, I just kind of let it go. I think I could still do it for 10. So we had him repeat it, and he was right. He was able to contract all the way through very effectively all the way through 10. Now, it was a little bit weaker, but he just did 20 palate contractions in a very short time. So I would say his palatine function, his vagal motor nuclei function is intact. And this would be maybe a little bit contradictory to what we hope to find, or what we theorize to find, which is that he's got a brain gut axis issue. It must be his vagus nerve not really firing into his gut. But this is really not what's happening here. His gut motility is absolutely not functioning well, and he does have motility issues. And when he says when he eats fiber, it really gets stuck and he doesn't feel like his food's moving. Those are all real. Those are all motility issues. But his motility issue may not be because of lack of vagal activity, but his motility issue is more likely from dysautonomia. So it's really probably from too much sympathetic tone compared to parasympathetic loss. So when we look at his case, this is like a scenario where you probably wouldn't do gargling or gag reflex exercises and so forth, because it's intact. You typically only do those when these pathways are off. So this really just confirms the fact that we really need to focus on identifying what area of the brain was injured, so we can start to rebuild that pathway. So the cortex, remember, has all these different autonomic centers, and when you find a brain injury and you can help it rehabilitate, then you typically can impact descending pathways that dampen the area of the spinal cord called the intermanual cell column, which has increased sympathetic tone. So with him, he's got a dysautonomia with increased sympathetic activity, most likely causing his motility issues versus lack of vagal tone responses.
Have you heard of this is sort of unrelated, but taking acetylcholine is sort of the mediator of vagus. Someone was saying, I forget who was listening to a podcast and saying, you could take nicotine and that will stimulate that receptor. So I tried that once and it was just,
what happened?
I ended up sweating and I didn't, I just felt nervous and very anxious. I was like, okay, that wasn't a good experiment.
You also took prokinetic drugs in SIBO, right?
No, I was taking Iberogast and Motil Pro.
Yeah.
So not any medical grade ones.
You said just a pharmaceutical. I mean, nutraceutical.
Not Reg something, Reglan, or, but the Iberogast or Motil Pro, those were the ones, prokinetics in terms of herbs.
Do they help you?
Motil Pro, the ginger is sort of burning, but I do notice that the 5-HTP in Motil Pro can kind of stimulate that parasympathetic response. So
the 5-HTP not only helps you with your sleep, but also helps you with your gut.
It helps just me calm down a little bit. But I never noticed oh wow, everything's moving perfectly now.
Mark provides us with some really interesting information here about how trying to activate his intestinal motility with nicotine really caused some significant issues. And when you look at the pathways in the gut that are involved with peristalsis, we have acetylcholine pathways, we have nicotinic receptors and various nicotinic receptors, and that didn't seem to work with them. And if anything, it caused his autonomic centers involved with sweating to get much worse. And then, trying the normal things like ginger really irritated his gut, because if you have poor you have a suppression of parasympathetic activity where you can't get blood flow to your gut, it just doesn't heal. So things like ginger that's supposed to help motility can really cause some significant irritation there. And, one of the things that seems to be helping him is taking serotonin precursors. And there's a descending serotonergic pathway that is also involved with motility and also just brain function in general. So you can see that he's really seeing some changes in his motility when he takes nutraceuticals that really support his nervous system. And those, again, point more to the fact that we have to really look at his chronic gastrointestinal issues more from a neurological mechanism versus to trying one probiotic after the rest. If you actually look at his history over a period of time, he really has taken virtually almost everything that's out there in the healthcare and nutritional world for his gut. So it would be really inefficient to continue trying to go down that same pathway. Okay, look up here. Just track my finger with your eyes. Try to keep your head still. want you to look at these two targets as fast as you can, left to right. Okay. Do you get those really well? Okay, let's do that again. So really go as fast, target these fast as you can. Fast, fast, fast. Okay, now when I move it, I want you to target to it. Okay, look straight ahead. Straight ahead. Try not to move your head. Okay, straight.
And then watch it or go back to center?
Just go back to center.
Okay.
And then you adapt really well. So this is just a visual eye movement part of the exam. First start with cover uncover test just to see if he's got any patterns of exophoria or any movements of his eyes that are abnormal from eye muscle compensation weakness. And we don't really expect to see much with this because he also had a pupil light reflex where his eyes were aligned. It's just part of going through a normal cranial nerve exam. Then we go through what's just a visual tracking pathway, and visual tracking is important just to make sure that there's no weakness of any muscles, but it's really more important to see if the movements are smooth. And smooth movements by tracking involve different regions of the brain, primarily the cerebellum, the frontal eye fields, and even different parts of the basic ganglia and brainstem are all involved with smooth pursuits, and those were all intact, meaning they had smooth eye movements. Then we tested something called visual saccades, and visual saccades are just looking at targets really, really quickly. And at first he had a hard time doing that, which was abnormal. And this appears to be really more related to what's called dyspraxia than it is to like slowness of the saccades or targeting accuracy of the saccades. He just had a hard time initially doing it, but then he really was able to compensate with those. So for the most part, it just lets us know that areas of his brain that are involved with visual pursuit, tracking, and saccades are healthy, and it still doesn't explain where we may have some injury and dysfunction, but that little dysfunction and coordination of this initial eye movement response is a pattern that we see with dyspraxia. So we're going to really look at his hand coordination and hand motor planning and leg motor planning a little bit closer to see if we see any imbalances there. That can let us know that we have some dysfunction in the premotor regions of the brain. And check your jaw. Relax your jaw. In this part of the exam, I'm just going through and checking his deep tendon reflexes, which are all intact. And then I'm going there and checking upper motor neuron signs. I flick his fingers to do a Chalmers test to see if there's any abnormalities. I do Babinski and stroke his foot to see if there's any upper motor neuron signs. I stroke his calf, look at Oppenheim to see if there's any pathological reflexes. Everything was intact. And then I just do a quick screen of his tone to see if there's any abnormals of tone. And everything was intact there. So these are all pathways that are really involve what are called cortical spinal pathways, the descending motor pathways, and there is no abnormal patterns found with this part of the exam. With your right foot, tap as fast as you can. Same with the other side. Both together. Okay, and take your hands like this and go like as fast as you can back and forth. Fast, 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 fast. Open, close, open, close, open, close. Okay, and then you go one at a time. Just to the right hand, as fast as you can. Faster, faster, faster. Other side. As you can. A little hard for you.
This one's a little harder for some reason.
Fast, 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 fast. Fast, 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 fast. And slower there. Try the right side again. You don't look at it. Here's what I want you to do now. I want you to do every other finger. I want you to go here, here, then there, then there.
Okay.
Here, here, there, there. Don't look. Fast as you can. Okay, left side.
It's considerably slower.
Yeah. This is what we call dyspraxia. Okay.
Interesting. Not as good.
That's good.
I wonder, yeah, because like when I play piano, this hand is more active, but I don't know.
And the left one isn't?
Not as.
Is it harder for you? Like, so you're right or left-handed?
I'm left-handed.
You are.
But I
left-handed.
play everything regular. But I don't know if that has anything to do with it, because this is the active hand on guitar.
So this is a function of the frontal lobe, the coordination and planning of movement sequences.
Mm-hmm.
And it calibrates with the area of your brain called the cerebellum. But we're looking at the speed. So one of the things that's important for me to go, which frontal lobe is really involved? So now we're saying, hey, if you're left-handed and that side's off, you get a right frontal lobe. That's a concern here.
Yeah, yeah.
You notice the big difference, yeah?
I do, yeah.
Okay.
Yeah, that is interesting.
Okay, here we see a significant examination finding. We see that he's having some significant issues with fine motor coordination. And fine motor coordination involves the premotor cortex and the frontal lobe on the opposite side. And you can see on his left hand he's having a really hard time. And he is left-handed, so this is not a left-handed, right-handed issue. His dominated hand is really the one that's involved. So when you look at rapid movements, there's some things that you really want to understand. If there's actual slowness, and slowness would mean just things are moving really, really slow, that really involves the basic ganglionic pathway. That's a dopaminergic pathway. That's what you typically see slow with people who have, for example, Parkinson's disease. He's not actually slow because of that. He's really slow because he can't figure out how to plan. So I first did finger to thumb on the right-hand side and left-hand side, and he's able to do that, and you can really see some imbalances. Then what I did is picked a pattern for him to do with alternating fingers, because that puts greater demands on motor planning, and then everything got much, much worse and much more obvious. So right off the bat, we know that he's got some issues with his motor planning issues on the left side, which means that his right premotor cortex is involved. And I made a comment there, hey, you knew there's something wrong with your frontal lobe, but just wouldn't know where or what part of it and which side. And that was because on the brain region localization form, which is a very, very effective form, especially if you don't understand all the clinical signs and symptoms from history of where different brain regions are involved with dysfunction and injury and early neurodegeneration. But on that brain region localization form, if you look at the case review, there's a lot of frontal lobe symptoms. And here we can see that when he had trauma, more than likely that this was the area that was injured, that right frontal lobe involving that premotor area, now leading to what's clearly seen as dyspraxia, difficulty planning motor activity. So it looks like his hand movements are slower. He's having difficulty figuring out which fingers to move to target the sequence that I showed him. Now put your hands like this. Go back and forth as fast as you can.
Both hands?
Yeah. Fast, fast, fast. Okay, now I want you to time them together. I want this one to go as fast as you can, and then I want this one to come in and catch up with that. So you're gonna go like this, and then have this one come in so they're at the same time.
Oh, so start.
Yeah, start with the right. And then hard to do.
It's a weird exercise.
Okay. Now start with this hand, back and forth, and then bring in the right side. That's pretty good. See the difference?
I'm just trying. I'm gonna do this one more time. I just want to make sure I understood it before I get
So
going.
go back and forth as fast as you can.
Yeah.
And then when you're ready, get
Bring
your
this guy going.
Yeah.
Okay.
Okay.
Oh, better.
Try this one. You can catch up.
I feel like I'm getting a little...
Just take a little break. But just even moving your head all the way up and all the way down.
Yeah.
Just do that as smoothly as you can on this side. And then to the other side. Do you notice the difference?
Not considerable difference.
Yeah.
Are you seeing anything?
It's a little more involved, not as efficient on this left side.
Huh.
And certainly slower.
Yeah.
This is like smooth.
Yeah.
So this is like smooth, and do this one again. It's like rusted.
Yeah, there's something going on with that.
So this frontal lobe, premotor cortex.
Mm-hmm.
We have to rehabilitate your premotor cortex.
And that would be on the right side.
So it crosses.
Uh-huh.
So your premotor cortex on your right side controls your left one.
Uh-huh.
Okay. So here I'm doing repeated supination and pronation, and typically when people do this test, they're looking at cerebellum function because the cerebellum calibrates muscle movement. So it turns muscles on at a sequence where it also turns muscles off, and if things are working well, then you have smooth movements. And when you look at Mark here, what we're really seeing is that you don't really see this cerebellar pattern of dysdiadokinesia. Actually, with dysdiadokinesia, when it's involved, you really see the involved limbs kind of just flapping all over the place, like it's moving out of plane, it's in all directions. You're just seeing that he's having a hard time coordinating that response, not calibrating. So coordinating that response is just that, things appear slower, but things appear slower because that area of the brain is not as efficient. Now, we're going to have to really check his cerebellum function, make sure there's no cerebellum involvement, because whenever you see this imbalance between supination and pronation, the cerebellum is still involved in coordination and working with this premotor cortex area. And then I have him put his hands out, and I really have him focus on doing these movements where he really has to stress out his motor coordination pathway. So have him start with one side and have the other hand come in. And that is all about motor coordination, and he just can't do it. He has a really hard time doing it. So that really confirms that his dysfunction is really not so much with calibrating muscle movement, but motor coordinating and figuring out how to actually initiate and start that movement, which is the premotor cortex that's involved here in the frontal lobe. I think you have a brush on your big toe, and this is a canvas out here.
Oh, so out here.
Yeah. A, B, C, D, E, and then F. Okay, and then you do the left side. A difference for you? C. Yeah. What did you notice?
Subtle. It's hard to tell. Maybe do it again.
It looks like you're having a much harder time with your left side. You're recruiting more. You're shifting your lifted body more.
Oh,
into
okay.
it. Try it again. Okay, ready? A. See where your hips are?
Yeah.
Okay. Try with the other leg. Doesn't feel as much of a struggle to you.
It does feel a little less...
Efficient.
Yeah.
Yeah. Okay. So we're going to work on that side with some things. So on this part of the exam, I'm just checking motor coordination activity in the lower extremity just by doing the alphabet. And when he does the alphabet with his right leg, it's much, much more smooth, efficient than when he does it with his left leg. Now, whenever you have an injury to an area of the brain, remember that there's a somatotopic map, right? So on the very top medial part, you have the expression of the feet, then it goes out to the knee and leg, and then it goes down to the arm. And as you get to the inferior regions of the cortex, you really have the somatotopic map of like the face and tongue and mouth. So we want to see how much of this motor strip was impacted. So we definitely know his somatotopic map of his arm representation and upper extremity was impacted, and now we're seeing that it also involves his leg. Fall back. You're gonna do that a few times.
Okay. Keep going.
Yeah. Okay, now when you come back, do the alphabet out loud, every other letter.
A, C, E, G.
Keep going. Get over to Z.
Oh my god. Gee, okay, I'm not very good at this.
It's okay.
I, K, L, M. This is harder than I thought, man.
Okay. So this is actually challenging your frontal lobe.
I don't know if I could do this without walking
Try it.
easily.
Don't walk. Do the other.
A, C, E, G, I, yeah, I'm not very good at that.
Okay, try to do even numbers out loud.
Okay.
Go ahead. Walk.
2, 4, 6, 8, 10, 12, 14, 16, 18, 20.
Okay. Try to subtract by threes as you do it. From 100.
Oh, okay, all right, I got it. 100, 97, 90. This is fun. 97, 93, 94, 91, 88, 85, 82, 79.
Okay, try sixes. Subtract from 100.
100, 94, 88, 82, 76, 70.
So when you look at Mark's gait, you can see that when he just walks up and down the hallway, he's got good arm swings, he's got good stride, all those phases of gait are intact. He's moving pretty well. There isn't really anything significant happening that's abnormal with his gait. And then we have him double task, and this is where everything changes. Now, double tasking is one of these things that you do to really bring out weaknesses. So if you have someone who's got, for example, balance issues and cerebellar vestibular issues, when you have them double task, they may have like instability when they walk, and they may get a wide stance gait, or they may sway or fall to one side as or move to one side as they're walking. It just brings out the weaknesses. You have someone who's got Parkinson's and you have them double task, they may just freeze and they get slower and they start shuffling and the arm swings stop. So really brings out the weaknesses of where there's involvement of the brain. So with him, you can see when we do it, he really has a really hard time coordinating his arm swings and movements and gait. This goes back to the confirmation that this is really a dyspraxia pattern. And we have to try different types. You can challenge the brain anyway. It just has to be somewhat difficult in involving cognition at the same time with motor activity. So we did every other letter of the alphabet, and then he wasn't sure if he could do that. And then we just did even numbers. That was a little too easy. And then we started subtracting by threes and sixes. He really started to have some problems there. So double tasking here clearly showed that it just really brought out his difficulty with planning his just normal parts of gait and movement, which further is an example of what's happening with an injury to the premotor cortex. Now hopefully as he recovers and is better, we want to be able to see him do normal gait analysis and movement with arm swings, and when he does these executive tasks, there's absolutely no change in his arm swings and his movement and his slowness, and that he has to take any pauses. So now we have a baseline, just like other examination findings are abnormal, to compare to down the road. There you go. Is that hard to do?
Not so much.
Okay, apply your cheeks. Okay. With your tongue, I want you to do the alphabet A through E on the right side, right cheek. Okay, and then the left side. Is there a difference for you? Is R one side? Can't tell?
I couldn't tell.
Okay. Go ahead and blink 5 times with your right eye.
Hold on.
Can you blink?
Yeah.
And then left eye. Right eye. And left eye. Right eye. And then left eye. You feel the difference?
I don't. Do you see something?
Yeah. When you blink with left eye, your right eye goes with it. When you do it on your right eye, you don't have your left eye blink as much.
My right eye goes with my left.
Watch. Go ahead and blink with your right eye 5 times. So your left eye is pretty open. Now blink with your left eye.
Maybe now that I'm aware of it.
Yeah.
It was just kind of going with it.
Okay. So if you remember, with the motor strip, we have a sphenotopic map of limbs, and then a leg in the top superior medial portion, and then as we go down the parietal lobe inferior, we have the arms and then the hands. And the most inferior portion of the sphenotopic map is the facial muscles and the tongue. So one of the things that we were just checking is how much of extent of this premotor cortex is involved. So what do you know? For sure his left hand is involved, his left leg is involved, it's just not as good. And now here we can see some issues with blinking. With blinking, the way you can just check efficiency is how much movement you see in the opposite eye when they try to blink. So you can see a big difference when he blinks with his left eye, he gets massive contraction of that right side. When he blinks with his right eye, his left eye is not moving much, just a little tiny movement. So we know that those pathways involving his inferior regions of his premotor strip are also involved. So he basically has his arm, his leg, and his facial regions of the sphenotopic map of the premotor area involved. So we probably want to think about it when we want to try to have him increase activity in those areas of the brain. Now remember, brain rehab is really, really simple. You don't have to make it complicated. Whatever they can't do is what they do. So he could literally just focus on finger tapping and a coordinated movement, or doing facial blinking and really focusing on trying not to have the opposite eye blink, and those things would all be therapeutic. Also, as you do dietary and nutritional things to support his brain injury and brain inflammation, if all of a sudden you see his motor coordination starts to improve, his gait with double tasking improves, then you know the brain is getting healthier. So physical examination findings can be used as a baseline to tell you what's not working well, and as you implement a diet, nutrition, lifestyle approach, you want to see if those things change. And then if you want to go a little bit deeper, you can just see what's not working, and whatever they can't do, you have him activate and do. And as he activates activities that he can't do, that's going to help support mitochondrial biogenesis and neuroplasticity in the area that's involved. What music do you play? Piano?
I play guitar, piano, bass, drums, and sing.
Have you noticed any difference playing with your right and left hand, like your left side, over time, like the past few years?
A little bit.
What do you notice?
I would say just a little less, maybe like speed.
Yeah.
But maybe also because I don't practice that as much anymore. I used to practice that a lot.
But there's a difference between right and left.
It's different with guitar. Piano would be more of like an even
Right.
distribution, or drums because you're doing this movement? Yeah, I would say it's hard to tell. It's hard to say, but in terms of over the years, I think a little less dexterity in general.
With the left
Maybe
side?
stiffness. I don't know if the stiffness is
On
like
the left or right?
good. Well, yeah, I think guitar is more left oriented because this is where all the action is. But piano, I would say both. It's hard to.
How does your brain feel when you play instruments? Do you feel
I
better?
feel good. Yeah, it's like it brings me into unless I'm like really computing and like or composing and like using my theory. But if I'm just improvising and playing for the joy of it, and or I'm playing a show or something, it brings me into a flow state, and then I'm able to just relax.
Right. So it feels like it's therapeutic for you?
Yeah.
And is guitar more therapeutic for you than piano, or is there a difference?
They're both. Yeah.
They both do it for you?
Yeah.
Okay. How often are you playing instruments?
Not as much lately.
Because it's going to be one of the things that will help support the area of your brain you need to activate.
Okay.
Because complex fine motor movements is what we're after.
Oh, okay.
So if you're already doing that with the guitar, you're already doing that with the piano, and you notice you feel better doing it, right? You feel more, your mood changes, your focus, attention, concentration
Definitely.
change.
Yeah.
You're already knowing how to fix your brain, you just...
Yeah, maybe I need to employ that more. I've been kind of like doing other things, but yeah, I could bring that in.
And how long can you play before you get tired? Have you noticed that there's an endurance issue with that?
Depends when I'm playing.
So technically, if you play things spontaneously, it won't be as challenging for your prefrontal areas as if you have to try to remember
a structured script or something.
Yeah.
Yeah, that would be more taxing.
Okay. Now, the most therapeutic part for you would actually be the structured script.
Okay. So like regulating dexterity and technique.
And try to try to coordinate your fingers to play the song.
Right.
And it's a new song, like learning new songs.
Okay.
Is going to be very therapeutic for you.
Okay.
But
I can get into that.
But if you do what you know how to do, you'll get blood flow to that area and start activating it, and then maybe go into some more challenging stuff.
Okay. Yeah.
But also, if you do too much, you want to look at your brain fatigue, okay? And see if it actually has an opposite effect, where it doesn't calm you down anymore, it causes you anxiety, and so forth.
If I'm overexerting the...
Yeah. So, if you have an area of injury, let's say, right? If you try to activate it, it doesn't work as well. Like your left side's seems like it's rusted in smoothness and calibration than your right side, the left limbs. And then activates the prefrontal area, right? But it's also an area where if it's injured and it's not functioning as well, you don't have as much mitochondria there, you don't have as much energy there, producing cells there, so it'll fatigue sooner.
Right.
Okay, but when it fatigues, and when that area of your brain fatigues, your whole brain will fatigue, and then it can't gate sympathetics, so you want to see if it causes your anxiety to come out. If it does, it means you're going too long.
Okay.
So I'd rather have you do like clinical ways to activate that area with things you like to do.
Yeah.
So playing new songs on guitar, really incorporating that left hand is going to be important.
Okay.
Okay, we're going to have some other things to do.
Yeah.
We're going to have you play with your left. We're going to play with your tongue on the left side of your cheek. We're going to have you blink.
Sure.
We're going to have you draw letters with your left side. We're going to get that whole system going.
Okay.
Okay, so the discussion we have here is really talking about how we can activate his right premotor area by having him do something he already loves to do. Now, there's something that's getting in his way of healing, because he's playing music, he's active, and he's actually doing a lot of coordinated activities. He's just not recovering. So it's really doubtful that just doing neurorehabilitation with him is going to change him. This is the exact scenario that if this person walked into a functional neurology clinic where they do brain rehab, he would be an absolute failure with that model alone. Just like he's not going to respond to someone that just goes and tries to treat his gut with different probiotics and nutraceuticals for his gut. I mean, it's just not going to have the impact. There's something that is absolutely getting in his way of his recovery, and this is primed glial cells. So these primed glial cells, these neuroinflammatory responses, is really what we're after. We have to really address that when it comes to the clinical management. We'll go through a step-by-step approach and really apply all the concepts that we talked about in the neuroinflammation course. So, when you have someone who's got an injury to an area of the brain that is then their daily activities activated and they still can't recover from a brain injury 10 years later, then there's the underlying mechanism that's involved. So that's the key thing here. Now, also with areas of injury, once you know what they are, just from doing a thorough exam, you can then understand what symptoms the patient can look for. So when there's an area that's injured, then mitochondria is less efficient in those areas. There's less neurons, there's less efficient mitochondria from the oxidative stress and from the inflammation in those prime glial cells, so they will fatigue much sooner. So if he comes back and says, hey, I did a protocol, I've been doing your protocol, and now I can play music like for 2 hours without getting tired, and before I could only do it for half an hour, that means you're really implementing a protocol that's impacting mitochondrial biogenesis, and he's able to recover, and that would be a positive sign. That's what we hope for him to look for. His endurance, and if his endurance levels change over time. Usually you'll see changes in endurance much sooner than you will see change of function. So whenever you find an area that's not working or something that's functional, figure out what their endurance levels are, and then try to quantify that with some amount of time of that activity. For some people, it could be driving. For other people, it could be standing. For other people, it could be doing cognitive tasks. Whatever it may be, depending on what area is involved. Quantify the number before they fatigue, and then use that as your baseline. And that's what we're hoping Mark can achieve during that discussion. I'm just going to check your balance. It's pretty good. Okay, close your eyes. Perfect. Open your eyes. Put one foot in front of the other. That's great. Other side. Pretty good. Okay, stay here. Feet together. You're gonna do it with your eyes closed now.
Okay.
Perfect. You can see that his Romberg's test and his tandem walking are fairly good. He has pretty good stability there, and then when his eyes close, he can walk in a straight line. And that lets us know that his proprioceptive input from his feet is intact. We already knew that when we went through and checked all his parietal lobe functions and checked the monofilament test and vibration sense and everything. And then we were also checking cerebellum integration, because these proprioceptive inputs come into the feet and they integrate with the vestibular system and help keep his postural stability. So his midline cerebellum is intact, and seems actually pretty healthy. I'm going to touch different fingertips.
Okay.
And then you're going to touch your nose with the fingertip I touch.
Okay. Just close my eyes.
Yeah, wait a second. Put your hands here. Relax. You got a little tremor happening. You feel that?
Yeah, a little bit. I don't know if it's because they're like sub-zero or what.
Yeah.
I need to do some jumping jacks.
This on your fingers. Between your fingers. Like that. Stick your hand out. You see the tremor now?
Mm-hmm.
That's called a physiological tremor. It's hard to see.
Yeah, I
And
see
then
it.
as soon as you
Yeah.
put it here, you can see
Yeah.
it.
And that's not normal.
It's not a sign of disease, but we want that to go away.
Yeah.
That's your sympathetic firing.
Okay.
It's like you had a whole bunch of coffee, you could do this.
Right. Yeah.
Let's put them both like this so you can compare. First on one side. Stand up like this so you can make it easier. Which more on the right? See See that?
Yeah.
So you can see Mark has a physiological tremor, and the physiological tremor is just a very low amplitude fine tremor. It's usually around 6 to 12 hertz, which means there's 6 movements per second or 12 movements per second. That's what 6 to 12 hertz means. And there's just very low amplitude movements, meaning you have to really look for them. And sometimes when you see these types of tremors, it's just easy to put a piece of napkin in someone's hand, and then you can see the napkin move. You can actually do that with all tremors to help see them better, but they're very, very useful for physiological tremor. Physiological tremors happen because you have way too much metabolic activity causing muscles to contract. So this will happen if someone's on way too much thyroid hormones. Remember, thyroid hormones increase muscle contraction. They also increase sensitivity of epinephrine, norepinephrine receptor sites and drive that cholinergic drive to muscles. And they happen when you have way too much sympathetic tone. And sympathetic tone increases catecholamines, epinephrine, norepinephrine, and you get that physiological tremor. You can induce physiological tremor to yourself if you just have way too much caffeine. And you can see that type of shaking response. Or if you've ever had some kind of significant stress response and then put your hands out and it was shaking up and down, that would be a physiological tremor. It's caused by increased metabolic activity of those muscles. And in his case, it doesn't seem to be thyroid, it seems to be his increased sympathetic tone. And then I want you to touch your nose, eyes open, and then touch my finger. And then on this side, other side, there you go. And keep doing that with just the right hand. Keep doing that just with the right hand. So you have a tremor all the way through. It's not a termination tremor, it's a physiological tremor all the way through. Okay, other side.
Meaning it's like traveling.
Some people only have a tremor at the very end of movement.
Oh.
Yours is going all the way through.
Oh, okay.
So it means a different thing. See, yeah, all the way through this way. So there's a tremor all the way going back and forth. It's not just at the very end. See, right through there, there's still movement. That means it's not a termination tremor, it's a physiological tremor. And that's different. Termination tremor is only at the very end. It involves the cerebellum. This is a physiological tremor. This is too much sympathetic tone, too much catecholamine drive. It's not as bad on this side.
I feel that difference. Like this one feels way smoother.
Yeah. And the other side, this one's much more clear.
Which is weird because we were kind of eyeing on the left hand last
That's
time.
for a different part,
Oh.
different movement, different.
Yeah, there's like a steadiness that's not as clear. Right.
So you can really see the physiological tremor with his finger to nose type of pattern. And, his finger to nose is fine. So he can target, he knows where his nose is. He can do it smoothly. So that lets us know his parietal lobe is functioning well because he knows where his finger is and he knows where his nose is. So there's no patterns of missing. And then his movements are pretty smooth. So muscles are turning off and on to target his nose. That lets you know the cerebellum is functioning well. But he's got this physiological tremor that's involved. And on the camera, it's a little hard to see, but if you look very carefully, you can see it. So remember, physiological tremors are a low amplitude, so you don't see huge movements. You see very, very tiny movements. And, his obviously has a little bit more on the right hand than the left hand, but it's there on both sides. You can just keep yourself stable here, okay? It's called a pull test. So this is just a pull test. This is one of the findings you'll see with early Parkinsonian patterns. It's just a loss of postural reflexes. And you do the pull test, and if they can't become stable after 3 steps, that would be a positive sign. Now, anytime you see people that have chronic gastrointestinal motility issues and constipation issues, you always have to consider the possibility of early Parkinson's, even young onset Parkinson's, which could happen in Mark's age group. And that is still a possibility with Mark. But, we have to just see how things show up in the future. With the early Parkinsonian pattern, you see more tone issues and stiffness and rigidity issues, lack of arm swing. We don't see any of those patterns with him. So we see that premotor cortex pattern, but there's still a possibility he may have some alpha-synucleinopathy that's starting in his gut, and he may have more than one thing. But as far as examination findings go now, there's no patterns of early onset Parkinsonism that may be a possible differential diagnosis for his chronic gastrointestinal motility issues. We're just looking at your vestibulo-ocular reflexes. Those are pretty good. Go ahead and stare at your phone. Look right there. In this part of the exam, I'm just checking his vestibulo-ocular reflexes. So I put these goggles on to look at his eyes, and I just move him back and forth in a chair. And you can see his eyes are bouncing back and forth really smooth at an even rate. They're not going off plane. And those are really healthy vestibulo-ocular reflexes. So that means his vestibular input to his cerebellum and his midline cerebellum are really, really healthy there. And then I have him stare at his thumb, and I keep moving him in the chair, and then just making sure his eye doesn't slip around and have any abnormal movements of eyes. We shouldn't have any ocular reflexes. This is called a cancellation reflex. When you have someone stare at their thumb, and then you move them back and forth, and those are intact. The normal vestibulo-ocular reflexes, what we first did with them, are really checking the deep cerebellar nuclei, and then when you have someone stare at their thumb and then move him in a chair, that is really evaluating the cerebellum cortex, those Purkinje inhibition pathways. And these are typically involved with people that have cerebellar ataxias and gluten ataxias, but his pathways are okay. So as we go through the examination, and we go through ears, throat, heart, lung, abdomen, all the different things, we see that he really has some patterns of increased sympathetic tone and dysautonomia. And then as we go and through his different examination findings, all the major regions of his brain are really intact except that frontal lobe on the right side, that right premotor cortex area. And this may be part of the reason he's got dysautonomia, because of injury to that region of his brain.